Good evening, everybody. My name is Greg Hoffmeyer. Thank you, Dr. Matosian. I am the marketing director for retina and glaucoma for Topcon Healthcare. I am based in Chapel Hill, North Carolina, and alongside with me today in Peru is our director of education, Dr. Jose Mendoza, who's going to speak on OCTA. So I'm going to go ahead and get started. Right there at the on the first slide, you'll see a graphic in the bottom left that highlights our three business sectors in the world, and that is agriculture, infrastructure, and healthcare. Next slide, please. So tonight we're going to talk about our nifty little fundus camera. It's called the Maestro 2. It's basically a robot. I like to call it the Roomba of OCTs. It's press a button and it just takes off. It's magical. And we're going to talk about what it can offer you in the clinic, and that includes retina, glaucoma scanning in both OCT and OCTA modes, also anterior segment OCT. And every time we do OCTs with any of our OCT fundus cameras, they always come with a fundus photograph. You can turn it off if you want. There's no reason to do that, quite honestly, but it's intrinsic to imaging is to have both OCT and fundus photography at the same time. And you'll get used to it really fast if you're currently using an OCT that does not do that. They're very easy to learn. The concept about Topcon is to get patients in and out of the practice quickly and to be run by pretty much anybody in the office, any technician. We know turnover is a huge problem in ophthalmology, especially at all levels of eye care, actually. And so it's very important to have technology that doesn't hold you hostage with a technician that is required to perform such, imaging. It's really not necessary. The bottom left image, why would I have a picture of a $750,000 John Deere combine on an OCT presentation? If you look at that touch screen in the middle of that image, that's actually the same form factor that we put on our device. That is an outdoor controller screen. It actually powers our Maestro, and it's basically takes directions from your technicians. It's made to be abused, and it's pretty neat technology. Next slide, please. So we're not going to talk about all these scans. Pretty much all the OCTs in the market do lots of different things. We're going to highlight two principal types of scanning. One is called the 3D wide cube scan. It's a 12 by 9 millimeter cube of data over the posterior pole that yields tons of reports and tons of data for your clinic workflow. And we're going to talk about OCTA. Next slide, please. So what's really neat about this machine is it's really, the owner's manual is in that upper right-hand corner of that touchscreen. There's a 1 and a 2. You literally raise and lower the chin rest, and you put the patient's pupil in that blue track in the bottom. You tap the patient's pupil and hit start. The camera launches, pulls itself into the eye, finds the pupil, automatically polarizes, focuses, and takes the sequence all at once. Backs up by itself, moves to the other eye, and does the same thing on the other eye, all in one sequence, typically in under about 45 seconds. Next slide is actually going to launch a sequence. You're going to see an animation here of what actually happens during capture. Notice on the fundus photo, there's a green line going from top to bottom. Those are OCT scans engulfing the posterior pole with data. Pretty neat stuff. That all takes about 3.5 seconds. So we want to get people to stop thinking about OCT in a specific way, like macula scans for retina, optic disc scans for the glaucoma patient, for instance. We wanted people to think about one scan for pretty much everything. Next slide, please. So this one cube, this is called a 3D wide scan. This yields several different types of reports. The most common is the one on the right, and that is a 3D wide standard report. And we'll talk about the next few in a couple of minutes here. Let's go ahead and proceed to the next slide, please. We'll highlight this 3D wide report. So it all starts with the fundus photo, and there's 128 B scans top to bottom. And in row 4, you'll notice heat maps. There's retinal thickness, ganglion cell, two types actually, ganglion cell with and ganglion cell without a nerve fiber layer. That's some referred to as the ganglion cell complex. That's an option you can use on this device. There's also retinal nerve fiber layer, cup to disc ratios, and all with reference data. We don't call it normative anymore. We call it reference data. Next slide. So same scan yields this report. This is called a 3D wide glaucoma report. Again, it's a 12 by 9 millimeter cube per eye, And what you see here is ganglion cell and nerve fiber layer thickness side by side. You know, notice on the nerve fiber layer heat maps, the retinal vasculature is actually pulled out of that image, and that is to unmask something hiding sometimes along those arcades, like wedge defects and thinning of the RFL. So sometimes the vessels will kind of maybe just detract your attention or kind of mask that. And there's two sets of data instant graphs, one per eye. And the reason we do that, the reason we don't mix them, is because sometimes one eye or the other may be outside the normative range. And you really can't blend images on top of each other as one is outside the so-called reference range. That's actually pretty common, and we'll go over those ranges in a second. But this is called the glaucoma report. This is very popular to assess the glaucoma or neuro patient. Next slide, please. So these are these ranges, and no matter what OCT you're using, this is probably somewhat common. You'll come across a report where some of your values are either grayed out or blanked out. And that's generally because the patient's age is beyond the reference range, and on the Maestro it's 18 to 88, or their optic nerve area is beyond the normative range, either too large or too small. Very common. If you have a Topcon OCT, these values are found on what's called a user's guide, which is available on our website. But we get calls like this probably twice a week. Where are my values here? It's usually because the patient's optic nerve is too large, actually. Next slide, please. So again, from that one wide scan, we can run trend reports. And what's nice about this is one shot per eye, you get optic nerve photos, objective optic nerve photos, RNFL mapping, ganglion cell mapping over time. So that's really nice. Easy to run. You can do it on the second visit. Generally, people don't kick those into the third or fourth visit, but tons of data here, again, from one large scan. I'll be very clear, you can still do the classic scans, you can still do optic nerve scans, macula scans, and there's change and trend analyses for those as well. Next slide. So this is one of those scans. This is the 3D disc trend analysis. And what's nice about this is the data sets are less interpolated. The B scans are much closer together. Precision is probably a little bit higher. But what's nice is in the bottom middle of that report, you'll see a table, effectively a spreadsheet of average thickness data over time per sector and superior, inferior, and average over time. Really, really nice, really elegant looking report to look at. And sometimes, as we know, those cup to disc ratios or those RNFL measurements are skewed for many reasons, and you'll always have that objective color fundus photo assess as well. Next slide.
Greg, we have a question.
Yes.
How does billing work and coding work when your Maestro 2 does such a comprehensive scan, and it's including optic nerve, fundus photo of the retina, and then OCT of the macula? So how do you know what to bill? And obviously you can't bill for all, right?
No. You bill what you generally bill for. If it's a glaucoma, if you're a diagnosis, you're billing glaucoma code. Even though there's macular data on there, you're not going to get audited for that. That comes up all the time. I do have some doctors who as far as fundus photos and OCT at the same day, they get worried about being audited about that. I've actually gone into machines and disabled the fundus camera for this mode just to make them feel better. But we work with Corcoran Consulting, and they're adamant about billing. That's not a concern on a 3D wide scan. Whatever you deem that the code is for that report, that's the code you use.
Thank you for clarifying that. So the others are like bonus data, basically, for the doctor.
Yeah, absolutely. And fundus photography bills higher than OCT, which is crazy.
Yes.
But that's still the case. But in this camera will act as a standalone camera as well. If you just want to do fundus photos, you can do that. I always question people about that. Why in this day and age would you do a fundus photo, just a fundus photo, when you can do an OCT at the same time, and vice versa? It just makes so much, to me, it's intrinsic. It's one and the same. But you can do it. I want to talk about this next capability. This is very interesting. This is called the Hood Report for Glaucoma. Some of you may or may not have heard about this, but this is from Don Hood at Columbia University, pretty world-renowned glaucoma researcher. And this basically takes data from that 3D wide scan and actually puts it into an algorithm It just presents data a little bit more logically, intuitively. So this is actually my eye. I'm actually a glaucoma patient. And this is a 3D wide scan done on me a couple years ago. And what this is the upper right-hand corner is an RNFL probability map. So this is minor fiber layer compared to a reference database about my age range, telling me where there's a higher probability of functional issues. It doesn't say I have functional issues. It doesn't say I'm going to get functional issues. It just shows on a very clear printout what you might want to start thinking about in terms of visual fields. Do you want to do a 24-2 on me? Or since this red deviation is encroaching on that central 8 degrees reflected by that circle in the middle, you might start thinking about doing a 10-2 on me. And let's go ahead and advance one slide, and we're going to back up a second, Jen. So here's my conventional report. If you look at the OS, you'll see a lot of red there. The average thickness is quite thin. So let's go back a slide, Jen. We'll go back to that left eye on the hood report. And so this is what it's showing you is a rather large wedge defect. If you look at that heat map on the bottom left quadrant of the report, there's an RNFL. There's actually quite an obvious wedge defect superiorly. So that is reflected in an inferior probability, a higher probability of functional issues. Pretty interesting stuff. And I can tell you as a patient, when this is put in front of your face compared to a report with a bunch of pie charts on it, this has an impact. This makes you think at night when you're putting those latanoprost drops in. This is the visual I see at night. Pretty interesting. So hood report for glaucoma, pretty neat. So there's probability map for RNFL, probability for ganglion cell. Let's go ahead and go to the next slide. Trying to keep on time here.
Greg, right now that map looks like the hurricane map about
it does look like a hurricane.
Florida.
Yeah. Well, visuals are important. I mean, again, you show this pie chart here to somebody, they might think they're looking at their Fidelity Wealth Management aggregate or something. I mean, it doesn't really, red is bad. That's fine. I'll see you in a year or whatever. But that hood report, it hits you. I wasn't thrilled the first time I saw it. But anyway, very interesting. And again, that's gleaned from a 3D wide scan, that big fat wide scan we like to do on everybody. Next slide, please. And here's my actual visual field. This is before I had cataract extraction and 2 eye stents put in last year at Duke. This is the total deviation. You can see some deviations there in that inferior quadrant, and pattern deviation takes away from the cataract, of course, but there's still some functional issues. Let's go, and you'll see the bottom left, you'll see the heat map from the hood report, somewhat of a correlation. Next slide. And on the next slide, you can see the grayscale there, kind of an uncanny matching of the hood report. Again, it's not the same. It's not an exact, you're going to have issues. It's just telling you the probability is high, and the reference data says you're in a grouping that's on the low end where you really don't want to be. Anyway, very interesting. This is from our Tempo perimeter. Next slide. This is a brand new perimeter we just launched at Academy last year. It does the same old single field analysis reports everybody's familiar with. The only difference between this and an HFA is this does have the global defect curve, which some of you Octopus users might be used to. And you can see on my left eye, there's actually a sloping downward indicative of that cataract. Next slide. Just real quick on the perimeter, just a little sidebar here. This is a binocular perimeter, which randomly tests each eye at the same time. 24-2 threshold test in under 4 minutes on a normal healthy eye. Glaucoma eye is a little bit longer, but what's really nice about this machine from a glaucoma patient's perspective is you cannot tell which eye is being challenged, which is very interesting because I'm quite aware that my left eye is worse than my right. So what do you think I'm doing? I'm getting tested on a conventional perimeter with my right eye patch. I'm probably trying a little bit harder. The stakes are high. The stress is high. This kind of takes that away. It's kind of odd, but it does. And it's very interesting. Next slide. Let's just go ahead and skip that one. Next slide, please. Conventional scans are there. Macular scans for macular-centric disease, that's their higher resolution. Always a give and take with OCT. If you want wide data, resolution goes down a notch. If you want high resolution, mass and volume goes down. So higher resolution, 5-line cross, and the highest resolution is a line cross. The Maestro is capable of extremely high resolution imaging. And the next slide will show that. These are just some normals. This is the 3D wide upper right-hand corner. And as we go down to the left, that's a 5-line cross. And at the very bottom, that's a single line, which is effectively 50 OCTs on top of each other averaged out. Just beautiful imaging. So if you have, for instance, a patient on Plaquenil or something, and you really want to look at that basement layer of photoreceptors, you really want to throw the kitchen sink at those patients, and you really want to do a lot of scans on them, probably 5-line cross, macular scans, and super high definition. Next slide. And these are just some examples of some higher definition disease slides. Of course, diabetic macular edema, again, with beautiful fundus photos. They're not always this perfect, to be honest with you, depends on the eye, but it's something you'll get used to really quick. The bottom left image is a big fat nevus right in the middle of the macula with a derived infrared image below the color, which is nice. Upper right is a histoplasmosis patient with CNV, and bottom right is a very healthy 15-year-old in extreme high definition. Next slide. And for retina specialists, the before and after, pre and post anti-VEGF injection, there's a really clever compare analysis which unifies total data sets and lets you scan through them in registration. And you can actually see a deviation from ETDRS central subfield, which is really nice to have. Next slide. And of course, anterior segment for anybody that's doing scleral lenses, it's really good for that. There's a little spacer that we put on the headrest. There's no lens you have to put on, and it provides really nice high definitions of images of the cornea and of the angle. Easy to do. Next slide. And of course, fundus photography, old school, 9-field, peripheral imaging, all done semi-automatically. The camera literally tells the patient where to look, and it blends the images together after the fact. You can do upwards of 9 images all at once, which is pretty neat. Next slide. There's a detachment there on the right. Set this up. This is my favorite. This is my thing, OCTA. Movement of red blood cells going through space, which is just crazy when you think about it. 8-micron cells that we can actually detect moving enough to actually build a vascular image of the retina, which is really neat. 92137, that's the number of the night. That is the billing code that we are told is coming January 2025, believe it or not. We're probably going to get an update on this in November to figure out what exactly it pays. We don't know, but it's not going to be 0. Next slide. This is the OCTA on the Maestro goes anywhere from 3 millimeter area to 6x6. If you're looking at diabetics and occlusions, you might want to go with a wider cube, whereas 3x3 is usually good enough for most retina patients. Next slide, please. This is a normal. So the top row shows you the so-called plexuses. We have the superficial outer, the deep retinal plexus, outer, and the choriocapillaris. And the bottom left image is your OCT B scan with a bunch of red flecks in it. That is actually flow signal. So that's a normal blood flow moving crossways through the retina, which is very, very helpful. It isn't talked about much, but we'll talk about that in the next couple slides. The number 3 is the composite at a glance with different colored plexuses, right? The superficial is in orange, the deep is in green. So that's blended into one at a glance composite, all with a fundus photo next to it, which is nice. The next slide is a obvious AMD case with subretinal fluid. You would obviously see this on a conventional OCT. This is not a big shocker by any means, but the imaging is quite striking. And you can see in the bottom left number 2 image, you'll see the flow signal just gushing through that CNV lesion. The image on the right, number 3, is the composite, and the CNV is showing clearly in the outer retina. That's why it's coded blue, because it's in the outer retina. So this is a 10-second scan. It's really nice to have this in your back pocket when you need it. You're not going to use it on everybody, but it's nice to have. Next slide. This is interesting. So sometimes when you're looking at OCTs, you might get a report that shows you 2 whopping B scans. That's it. And you're going to make a split decision based on that. You may not be in the position to scroll through the scans, but with this image on the left, this is a classic double hump pattern that we see in CNV, little pocket of fluid there maybe, but your report may not be on that B scan. Whereas on the OCTA, same patient, it's pretty obvious something's going on with this patient. The flow signal is highly increased of subfoveally, indicative of CNV, and sure enough, in the outer retina and the composite, there's a blue lesion. That is classic CNV. So not necessarily quiescent CNV, but nonetheless, it's pretty obvious. You're going to catch this stuff. It's pretty neat when you do. So for the cataract workup, maybe instead of conventional OCT, to make absolutely sure, take that extra 10 seconds, do an OCTA, just sweep that macula, make sure everything's flat and dry. You don't want to be surprised after the fact. As we know, that happens sometimes. Next slide. And I'm going to wrap it up here. I think I'm just about done. And Jose, right at 20 minutes, is going to be waiting in the wings. Harmony is something I'll just cover real quickly. But Harmony is a PAC system, an imaging EHR, which we offer, which is really nice. It's a cloud-based PAC system, which basically unifies all your devices into one nice software. And what's really nice about it is it uses something called modality work list, which a lot of people really don't know what that is. But modality work list is something that your front desk people send out in the morning with your schedule of patients for the day, and the patient's demographics pop up in every device in your office just waiting to be used for testing. So there's no data entry when you're using Harmony, which is really, really nice. So in addition to getting your images quickly and fast, everything, the workflow is tighter and there's less transcription errors. Pretty neat stuff. Next slide. And I think we'll go ahead and go to the next slide here. I think we're going to go ahead and get Jose on deck. And Jose is going to talk more in detail about OCTA. And hopefully we'll have some more questions towards the end. We'll be happy to answer. Thank you so much. Take it away, Jose.
But
Thank you very much,
Jose,
Greg.
before you start, I just want to say, Greg, that was really great. And I know you have a limited amount of time, but you taught us so much about OCT. There is a question about the hood glaucoma report. That looks
Sure.
really, really interesting. Is that proprietary to Topcon?
I wish I could say it was. There's one other company that offers it in another way. It's a Heidelberg. So Heidelberg does have it, and Don Hood actually came forth with, I didn't talk about this, I should have, but the RNFL is presented in the so-called in-stin configuration. So T-SNIT, you've all heard that phrase before forever. T-SNIT is the conventional way of doing it, but in-stin is something Hood put forth where it's the same circle we always do around the optic nerve peripapillary, but we actually place the macular temporal sector in the middle of the graph. And the reason why we do that is because that's the one that affects macular vision. So oftentimes you'll notice on your glaucoma printouts, the T-SNIT, the values drop at the end of the graph. That's the most important part. So that part should be really in the middle. It's very clever. We offer it with or without. And I didn't want to just go into that detail, but it is pretty neat. But Heidelberg does offer it to a degree. They just don't have the probability maps like we have.
Got it. Well, thank you very much. And
Thank
now,
you.
Jose, we want to hear all about the OCTA clinical cases.
Thank you. Thank you very much, Greg. Great introduction. So my name is Jose Mendoza. I'm an ophthalmologist based in Lima, Peru. I got a master's degree in clinical ophthalmology, was a research fellow from Stanford University, and I've got a major in image diagnostics and refractive surgery. So been a consultant for Topcon for quite a while, almost 10 or more years. And I'm going to talk to you about some clinical cases about OCTA that it's going to be launching this year at AAO in Chicago. Next slide, please. So OCTA is a non-invasive, fast, reliable way to see the blood flow in the retina. OCTA can be repeated as much as wanted and has lots of room to improve. When I was at med school, we been teach how to interpret FA images, but right now we could do almost the same without seeing the dye getting out of the eye non-invasively. So that gives a lot of information and will help a lot for doing several diagnoses. Next one, please. So the first thing you need to know is this is analogous to FA, but it's kind of different. You need to describe some key features in the OCTA images, including density of the capillarities, morphology, areas of non-perfusion, sometimes areas of hypoperfusion, where you could see slower blood flow, presence or absence of neovascular membranes, size, location, some flow characteristics, and also highlight the importance of comparing OCTA findings with structural OCT images. Greg was talking about multimodality. Multimodality, we have that available in all our equipments. You could have fundus photograph, you could have the B-scan, and also right now you could have OCTA that will improve your diagnose capabilities. Next one, please. So these are the 4 normal OCTA slabs. Greg was talking about this. We have the superficial plexus, then we have the deep plexus. This is actually the first time we could see the deep plexus in vivo when we do FA due to the color and dyeing in the retina. We couldn't see the deep plexus, and this is really important. Right now, we could see small lesions, small vascular lesions, such as diabetic features, microaneurysms, intraretinal micro abnormalities, deformation of the foveal vascular zone. All these kind of features, we could see it right now on the deep plexus and give us a lot of information. The other two, outer retina and choriocapillaris, each one will show, usually outer retina will be black because there is no blood flow at this level. This is the level of the photoreceptors, and choriocapillaris could aid a lot when we're talking about AMD or choroidal neovascularization. Next, please. So OCTA clinical indications is best used for any kind of pathology that will affect the blood flow of the eye. So CNV, we're trying to look at neovascularization. So we're looking at these new vessels. When we have central serous retinopathy, chronic cases could also come with neovascularization. So it's also helpful for this. If we want to monitor and diagnose retinal diseases, I've been talking about diabetic retinopathy, microaneurysms, capillary drop-off in diabetic retinopathy as well, retina vein or artery occlusion or branch occlusion. All these kinds of pathologies could be used, OCTA's clinical use for all of this. If we're looking at macular telangiectasias, MACTEL2, or polypoidal disease, or even tumors, we have a lot of information about using OCTA. Retina check on AMD, pre or post cataract extraction, that's also an indication for this. Next one, please. So we're going to jump into some clinical cases. Next. The first 2 ones will be about diabetic retinopathy patients, and I want to show you some of these cases related with FA, color fundus photography, and also the V-scan, so you could relate how this information is really helpful. Next, please. So this is a 49-year-old non-Hispanic female with ocular history of PDR and DME, and also cataract. You could tell cataract because of the color fundus photograph is not that clear. At the study visit, we could find hemorrhage, exudates, microaneurysms, diabetic macular edema, intraretinal microabnormalities, cotton wool spots, and minimal retinal thickening. So we used this, and the greater consensus for the OCTA images was correspondent to diabetic retinopathy. We could see microaneurysms and this drop-off retinal ischemia. Next one, please. So in this slide, you're going to see the characteristics of diabetic retinopathy. Pay attention to the 2 first plexus. In the superficial plexus, you will see the vessels are totally different on the ones that we see on the normal patient. And also, there is more black beneath that blood vessels. Also, in the deep plexus, and you could see some white spots that are really bright on that plexus. The next thing that you will see is that both foveal vascular zones start losing their regular rounded shape and start looking pretty different. On the last 2 plexus, there is no no data or no pathology, because these are most reflected in the superficial and in the deep plexus. Could you go one more, please? You could see more detail here. You could see on the green arrows, that will be microaneurysms. This really white, bright spots, these are microaneurysms. Really easy to spot with this OCTA technique. On the other hand, the yellow arrows will show retinal ischemia. This is areas where there is dropout of the capillaries. That's why they're looking black. So in OCTA, white means that there is blood flow there. If you see black, it means there is not blood flow there, or it's really small flow, this really slow flow there. In this case, the drop off of the capillary will come into retinal ischemia in those areas. The third photograph is just to correlate with classic FA. You could see the same location from for the microaneurysms, and the same location as well for the retinal ischemia area. Let's go one more, please. This is the second case. This is the left eye of a 71-year-old female with ocular history of non-proliferative diabetic retinopathy, got dot blood hemorrhage, DME, glaucoma, PVD, pseudophakic cataract. When we look at the ophthalmoscopy examination, there were microaneurysms, diabetic edema, and PVD. You could look at the V scan over there and see some of these characteristics as well on the color-funded photo. But as Greg said, when we go to the OCTA image, please one more, you will see that all these features come all together and look quite interesting. Here, again, please look at the two first plexus, the superficial and the deep plexus. Again, you will see all the vessels start to move a little bit. They're not more, they're a little bit elongated. On the deep plexus, foveal avascular zone is totally, has totally disappeared. There's a lot of microaneurysms and a lot of ischemia again. The other two plexus, the outer retina and choriocapillaris, they don't, you don't see any changes there. Could you go one more, please? Here again, you will see the yellow arrows will point you into the retinal ischemia areas, the black dots over this patchy vision, and the green arrows will show microaneurysms. There's the same relationship that you could get with the FA image. You could see the microaneurysms are in the exact same location, and also the black patches that you could see in the deep plexus is well correlated with the FA image as well. Can we go one more, please? So these two cases are going to be about CNV. So you will see the difference that there is between pathology where you have some areas of drop-off and ischemia with areas of neovascularization in this case. Next one, please.
Jose, before you go to the next few cases, with microaneurysms that you are demonstrating in areas of ischemia, is there a numerical or percentile number that the Maestro 2 or your devices represent? Or like, is it the interpretation of the person reviewing the images?
It's mostly interpretation of the person reviewing the image. Right now, you don't have like a reference database for this, or like an area where you could measure or get some metrics about this. It's mostly what you're seeing and interpreting of this findings. There are a lot of correlations with FA and as well as OCTA in this moment. They are both subjective examinations.
Thank you.
No problem. So let's review this one. This is choroidal neovascularization. It's the right eye of an 83-year-old man, female, sorry, with ocular history of neovascularization, AMD, CNV, and CME, PED with partial vitreous detachment. We see all these features during the ophthalmoscopic examination. you could see also the color fundus photos showing all these features. And in the B scan, here is the angio B that Greg was talking about. And I really agree with him. I really love this feature. This will show different flow patterns in the choroid and different flow patterns in the retina. So you could actually pinpoint the location of the lesion and see if there is a lot of red over there in the choroidal part that is getting into the retina, that it's really easy to look at neovascularization in different parts of the eye. Let's get one more, please. So this is the OCTA of this patient. Now let's take a look at the two latest squares, the two latest plexus, outer retina and choriocapillaris. There is some shadowing in the superficial and the deep plexus. This is due to the image acquisition. But if you look at the outer retina, we were seeing on all the other cases, outer retina was totally black. In this case, where the arrow shows you is a lot of branches of this choroidal neovascularization, that it's a start in the choriocapillaris. That's why you see a lot of changes over there, but it is getting into the retina with these new vessels that will, after a while, start leaking and getting all the different pathologic findings that we get with the latest stages of the disease. You could get one more, please. So this is the choroidal neovascularization again, the same patient. We're seeing the blue arrows in this case. Blue arrows are showing the CNV in the outer retina, really clear over the black, all this patchy white pathologic, and also in the choriocapillaris area. The last one is the FA that will show you how it relates the same localization, the same areas, the same whitish appearance of the dye getting out of the blood vessels that we are seeing here non-invasively with the OCTA. One more, please. So this is another case 4, CNV as well, 74-year-old male with ocular history of neovascular AMD, CNV and vitreous syneresis. We find all the same on the color fundus photograph, as well as in the ophthalmoscopy examination. And also on the B scans over here, we could see the same blood flow appearance in several parts of the retina and the choroid. One more, please. This, again, is the OCTA. Here you could see superficial and the plexus looking quite well. And in the outer retina, just a small white dot where the arrow is showing a really small lesion. If you see the choriocapillaris, you couldn't even see any kind of lesions over there. Could you go one more, please? Here you could see pretty well outer retina, choriocapillaris, and in the FA, the localization of the same lesion. So AMD, choroidal neovascularization, could be classic big membranes, or could be really small dots where you could see blood flow going into the retina in places that it shouldn't be. And this case is really important and impressive because it shows you the capability of the technique to detect even smaller and subtle changes in the retina. And we could identify and start treatment of these patients really, really easily. Next one, please. So this is, I think, my last case. This is diabetic retinopathy. So it's a 67-year-old male with ocular history of PDR, ERM, vitreous hemorrhage, and PVD. Of course, some cataract. You could tell that from the color fundus photograph. And there is the B scan. This really is important because you could see how the color fundus shows the cataract, and you could do an OCT, you could have a good image even through this kind of cataract. And one more, please. Here it's really, really impressive the way you could see the detail of the different pathology. Again, in this cases, this is diabetic retinopathy. We're looking at the superficial and the deep plexus. You could see really good where is the lesion, where are the parts that are non-perfused, where is the part that is normally perfused, and where are neovascular vessels trying to perfuse different areas. One more, please. You could see here with detail, the green arrows show microaneurysms. Again, this really white dots that you could see in the images, and yellow arrows show capillary drop off and retinal ischemia, all that black area over there. There is no perfusion over there. So you could detect easily where are neovessels and where are no perfusion areas. One more, please. So in summary, one more. OCTA has clinical implications that we need to explain findings. These findings can influence clinical decision-making. It could guide treatment, decision in retinal vascular diseases and CNV. It could monitor disease progression and response to therapy. If we're doing like anti-VEGF therapy, we want to see the shrinking of these neovessels. That could be done like on a daily basis. No one does do that on a daily basis, but you could do that like every week. So you could get a lot of more information about this. It could provide valuable information for surgical planning. Next one, please. There are some limitations. You've seen that there sometimes due to the acquisition or the kind of pathology of the patient, the details could be not quite well. There are some motion artifacts and projection artifacts as well that could affect the image quality. Some system has an inability to visualize deeper choroidal vasculature. And also we need careful interpretations and correlation with clinical findings as well. So one more, please. So takeaway. We need to summarize the key points discussed and emphasize the role of OCTA as a valuable adjunctive tool, as we were talking about using multimodal imaging, color fundus image, B scans, OCTA, all this in just one machine will improve the clinical decision making and also the evaluation of retinal and choroidal vascular disorders. We need to follow a structured approach where you can effectively communicate the clinical utility of OCTA, facilitating the understanding of this new technology. Next one, and I think it's the last one. Yes, I think we have some time for questions.
Jose, your presentation was excellent. I love the cases that you chose, and I loved the images that correlated with the cases. The Maestro truly has impeccable imaging. I'm very impressed with what I've seen.
Thank you.
So that's great. We did have some questions coming in, and Greg has been great at answering them along the way. So thank you very much, Greg. For a new technician to learn how to use the various features of the Maestro 2, how much time does it take, and what is Topcon's role in educating or training the tech? And I'll open that to anybody at Topcon.
Sure, I'll start, and then Greg could tell his point of view. I will say, as he started saying, this is a robotic OCT, and that you have just 2 steps to follow to get the images. That is for any kind of image. So you will use the same 2 steps for doing a regular B scan, 3D cube, 3D wide, OCTA, anterior segment OCT, or even color fundus photo. So it's just the same 2 steps to take all the different pictures and getting all integrated together. So for the technician point of view, I think that they love the equipment. It's fast, reliable, and really easy to use. And on the other side of the road, I would like to say that this is also helpful for ophthalmologists or ODs, because when you had an equipment that is totally dependent on the person using it, and that person moves along and go to another part, then you have to train another person to do it. That is not true with this kind of equipment, since they are totally robotic. You could teach a person to use the equipment and get great images in just a couple of hours.
That's really wonderful to hear. Clearly, there is a shortage of technicians and there's a lot of turnover, as you all mentioned at the start of the program. How about for the doctors, the physicians, the ophthalmologists and optometrists who are interpreting this? How much time is it going to take for them to really master the various images and their interpretation? And who helps the doctors with this?
Sure, I can take that to a degree.
Okay.
So it's like anything, you know, whatever you got to put some work into it as well, right? So initially, the technical training is pretty straightforward with the technicians. They're off to the races. 10, 20 patients they'll see of various, you know, degrees of difficulty. They're going to be pretty good. And as robotic as the Maestro is, it's completely manually overrideable. So we want to make that really clear. That's pretty neat too. Kind of like taking your car off cruise control or a stick shift, if you want to do that, if you will. But for interpretation, we do offer courses at Topcon Healthcare University, which is quite excellent, actually. You have to set up an account to get on there. And there are other third-party learning modules that are available as well. One really good one is called iCare PD. I forgot to disclose in my bio, I used to be head of imaging at Duke University before I went corporate many years ago. And I was working for another German company before Topcon. So all I've done for 30 something years is imaging, right? So I do a lot of follow-up training as well, one-on-one with doctors. Sometimes what I'll tell sales reps is to have the doctor call me 2 or 3 months after they get the machine, after they've accumulated a bunch of cases, and we'll go over some stuff with them. So we can help in that regard. But there are several really good resources within Topcon to do that. And of course, you know, there's educational groups at Academy. We're doing a glaucoma OCT workshop we do every year. Well, that's a popular thing. We'll have 80 doctors in that workshop for like 3 hours. So lots of online education, lots of in-person education at the major trade shows. And believe it or not, we do a lot of training at our booth at the big shows. A lot of doctors come back and they rave about their machines. They all pretty much love them. Sometimes we get some feedback, I'll be honest with you. But overall, it's usually a more immersive, like, hey, I love it, but I want to learn to do more. I want to do like more anterior segment imaging, for instance, stuff like that. So it's never ending. And I tell sales reps all the time, no deal is done until the doctor is happy. So it's continual.
Well, that's great. That's great to hear, Greg. And I really appreciate the follow through by Topcon to work with the doctors depending on their level of interest and kind of their level of wanting to learn more and more about the various images and how to interpret them. So thank you very much.
Thank you.